Hello and welcome. My name is Nicole East. I'm the Executive Director of MOAS. In recognition of Lung Cancer Awareness Month, we are pleased to bring you this webinar on lung cancer screening and prevention. I'm pleased to introduce our moderator this evening. Dr. Joel Lamon is a medical oncologist from the California Cancer Associates for Research and Excellence, or CCARE. Dr. Lamon specializes in solid tumors with an emphasis in lung cancer. He is the director of the Preventative Lung Cancer Screening Program at CCARE. I'm also pleased to introduce our panelist. We have Dr. Edna Flores. She is a board-certified medical oncologist from CCARE. She believes that cancer treatment is more than just medicine. It's also about compassion, prevention, research, and wellness. One of her goals is to combine compassion with cutting-edge clinical care to reduce patient suffering and increase quality of life. And our other panelist is Dr. Alberto Bessudo. He is also a medical oncologist from CCARE. He specializes in solid tumors with an emphasis in lung cancer and GI. He is also the director of the clinical research program at CCARE in San Diego. He is passionate about research and development of new targeted therapies in cancer treatment. So without further delay, I'll turn it over to Dr. Lamon.
So hello, appreciate this kind introduction. Doctors Flores and Bessudo are with me in the same office, so we'll be switching off as we move through the talk. I'm going to move through these slides. I do it correctly here. Is it down there? Great. So we'll follow me with the slides. This is all about early detection for lung cancer using low-dose CT screening as the focus of our program here, and is something that's been widely adopted around the country. Overall, we'll look at lung cancer history, practical issues of lung cancer prevention and screening, concepts of payer support, and touch on the issues of non-combustible tobacco that's dominance in our community. I want to start off with the history of lung cancer. Looking back at lung cancer with autopsy studies from the Institute of Pathology in Dresden, Germany, back in the 1800s. And what's important here is that Germany was a focus of Western medicine in these years in the 1800s. And in fact, the Dresden Institute of Pathology is particularly useful because there was a very big tobacco industry in Dresden. In 1878, they reported 1% of their cancers to be lung. 1918, 10%, and 1927, 14%. I want to acknowledge that we know cancer is a disease of aging and that life expectancies have changed, but I think this information is useful that lung cancer was not considered a significant problem in cancer. In 1876, there was a cigarette manufacturer, Allen and Ginta. They offered a prize for getting a machine that could speed up making cigarettes. And James Bonsack, they called it the Bonsack device, patented a cigarette machine, a manufacturing machine. And there was uncertainty with the people that gave the prize that they didn't need that many cigarettes. But James Duke, who is, I don't know which tobacco company he founded, but became fabulously wealthy because he took that Bonsack machine. He made a lot of cigarettes and sold a lot of cigarettes. That was in the 1880s. 1870, let's see, where were you? Page up or down? In 1912, it was Dr. Isaac Adler in the United States, and he noted in an article he published that primary malignant neoplasms of lung are the rarest forms of the disease, but he was aware of some anecdotal observations of more lung cancer in people that were smoking. In 1929, a German physician at the state hospital in Germany published a statistical evidence linking tobacco smoking to lung cancer. That was received as in the emerging Nazi Germany as a positive in the sense that they felt cigarette smoking was a bad habit, but it didn't get much traction. And during the 1920s and 1930s, lung cancer was perceived as an occupational disease. There were a lot of mines in Germany and Czechoslovakia, and they suspected there was an exposure to arsenic and maybe radiation. There was a note that radon gas measurements in some of these mines were greater than 18,000 picocuries per liter. That's a liter of gas. But in fact, I pointed out here that the EPA recommendations currently for home safety is radon less than 4 picocuries per liter. And so this was a significant exposure to the patients, for those workers. In 1930, the Springer Handbook of Pathology talked about lung cancer diagnoses. They noticed an increase from 1900 and accelerating in World War I. And they noticed a predominance in men and a rising rate in women. And they had a lot of speculations. Now, I put speculating smoking, but in fact, in their discussions, smoking was the bottom of their list. They thought about the increase in the number of cars, increase in paved roads, toxic exposures during World War I, and of course that was limited to soldiers. Also, the influenza pandemic of 1918 as possible factors in increasing the frequency of lung cancers. It was in 1950, Winder and Graham published a retrospective study that there was a higher rate of tobacco smoking in lung cancer patients compared to other diseases. And it was in the 50s and 60s that there were some prospective trials that showed the higher risk to develop lung cancer among smokers. It was in the 60s that cigarettes became labeled as possibly hazardous to your health. I put in this last statement from September 1986 just to point out the long lag of the medical community to deal with the smoking and tobacco, the smoking and lung cancer relationship. It wasn't until '86 that LA County medical facilities banned smoking. I can tell you in the hospitals that I was affiliated with in '86, '87, we still had cigarette machines in the hospital, and it took the medical staff debating this and discussing that we should ban the cigarette smoking in the hospital and the machines. So it was a very long delay in accepting this and for the medical community to stand up for what they recognized. And then we move forward to January of 2011, when the National Lung Screening Trial was done. Now, in terms of deciding how to screen or detect cancer early, there were lots of ideas, and we might touch upon them later in our talk, but they used the new technique of CT scanning, using a technique using low-dose exposure to radiation with a spiral CT. They compared it to chest x-rays for screening patients who were older and either heavy smokers or former heavy smokers. They demonstrated in the study a 20% mortality rate reduction in patients who had the low-dose CT screening compared to other patients. This was a seminal study because it opened the door to Medicare recognizing this and in fact paying for low-dose CT screening. I can't speak on other payers at this time in terms of commercial payers, but now it's a recognized valuable tool. With debate and controversies we might touch on into the concepts of screening, risk of screening, and it also some of the Medicare requirements in terms of bring patients in for low-dose screening, where they ask for pre-screening discussions and education regarding the nature of screening, all the risks of screening. I'm going to turn this over now to Dr. Flores.
So yeah, I'm just going to review a couple of facts regarding lung cancer. The lung cancer occurs when there are abnormal cells in one or both lungs and they grow out of control and form a tumor. They can interfere with the lung function, oxygen flow, cause symptoms like cough, shortness of breath, hemoptysis. Looking at normal, healthy lung, it should be nice and pink. You don't see any black. Patients with lung cancer, as Dr. Lamon touched upon, increased risk of exposure from pollution, as well as tobacco and other toxins can cause darkening, blackening of the lungs. About 230,000 Americans per year are diagnosed with lung cancer. It's the leading cause of death by any cancer, and more Americans die of lung cancer than from breast, prostate, or colorectal cancer combined. Dr. Lamon talked about some of the causes of lung cancer, and we know that combustible tobacco is one of the major players. More than 95% of lung cancers are associated with smoking cigarettes, and 20% of Americans smoke or are former smokers. And of course, secondhand smoke increases lung cancer risk. Something that's more popular nowadays is the non-combustible tobacco exposure, such as e-cigarettes, nicotine, smokeless tobacco, and other substances. As Dr. Lamon mentioned before, some of the environmental and industrial exposures, including radon gas, uranium, arsenic, coal products, vinyl chloride. So for lung cancer screening, as he previously mentioned, CT scan seems to be a better test than chest x-rays. And what we have found is that when we detect lung cancer early through screening, we can identify lung cancer before symptoms appear. And of course, with any type of cancer, it's always best to detect it at an early stage before it has spread, when the chance of cure is greatest. What we have found is that lung cancers found early in screening protocols have proven to be more responsive to treatment as well. So how do we determine who the right people are and what the right screening test is? So the right people who qualify for annual low-dose CT screening, this is per Medicare guidelines, and this was just recently updated in January of 2022. So patients who have a heavy history of smoking, and that's defined as 20-pack years, patients who are currently smoking or quit within the last 15 years, and are between the ages of 50 and 80 years old in fairly good health. And of course, we want to counsel them to quit smoking if they are current smokers. The right test is a low-dose CT scan. It's the only approved screening test for lung cancer. Compared to chest x-rays, low-dose CT scan reduces the risk of death from lung cancer by 10 to up to 20%. Now, low-dose spiral CT scans can detect abnormalities the size of a grain of rice, whereas traditional x-rays can only detect tumors about the size of a dime. And as we mentioned before, the smaller the tumor is at the time of diagnosis, the greater the chance of cure. I'm going to pass this on now to Dr. Bessudo, and he can explain how the low-dose CT screening works.
Hello, good evening. So from the national clinical trial that Dr. Lamon mentioned, LDCT became the standard test to screen for lung cancer. And as he mentioned before, this test practically reduces the mortality of lung cancer by 20% in the population selected by that clinical trial. So it's a special X-ray machine that you can do a CAT scan without contrast, delivering very low doses of radiation that I will mention a little bit later about dosing of radiation. And of course, this X-ray machine is linked to a computer that generates the images for us to screen for early stages of lung cancer. The benefits of LDCT, low-dose CT lung cancer screening, are it's much more effective than chest X-ray. On that national clinical trial, it's called the NLST. They compare LDCT versus lung cancer versus chest X-rays. So low-dose CT scan versus chest X-rays, and the low-dose CT scans was much more able to find lung cancer and reduce the mortality of lung cancer by 20% compared to chest X-rays. The scans produce much better images, as you can see, right? Very good at identifying small lesions. You do not use contrast. There is no risk of renal failure or allergic reactions to the contrast, and uses much more less radiation than the standard CT scan. The radiation on these machines is like flying on a plane. Just for you to have an idea how radiation works, we use these units called millisieverts. So normal chest X-ray uses 6.1 millisieverts. It's like 2 years of just living in normal space in this planet. A bone density is 0.001. So when you order osteoporosis screening, it's very low level of radiation. In contrast to nuclear scans, a nuclear scan, a PET CT scan, can be 22.7 millisieverts. The low-dose CT scan, actually in 10 years, those would be 9.3, meaning 0.9 every time you do the test. So it's much more radiation than a chest X-ray or any other imaging technology. Low-dose CT scan lung cancer, as I said, reduces 20% the cancer mortalities. And it's very well known on this point that only 4.4% of the people that should be doing the screening are doing it. So if we want to decrease the mortality and the incidence of lung cancer, the #1 mortality in America right now, we just need to promote patients at risk on that list that Dr. Flores mentioned for them to go and get the low-dose CT scan performed. Who are the right people to get this scan done? Well, the people that are at risk that we have already mentioned. Johns Hopkins Institute of Diagnostic Excellence Research found diagnostic errors were the most common, most catastrophic, and most costly of medical mistakes. Misdiagnosed cancers were associated with death or serious permanent disability in 30% of patients studied. More about the clinical trial that pulled out this study about doing screening low-dose CT scans. This clinical trial actually testing 53,000 patients, CAT scan versus chest X-ray, and it was only 33 sites through America. And the results were, as mentioned before, Dr. Lamon and myself, 20% decrease in the mortality of lung cancer. And remember, emphasize that primary care and the population in general needs to learn that the centers of screening lung cancer can be very helpful to find cancer in those patients at risk. Where can you get a LDCT scan done? Well, you need to go to a specialized center, right? This has to be imaging centers that have a loan program for low-dose CT. You don't want to be having normal chest CTs. Normal chest CT has 7.7 millisieverts as compared to the 0.9 of the low dose. So it does make a difference. So what we do at CCARE, CCARE has a program, a lung cancer program, guided leader Dr. Lamon. And we established this because we see lots of patients that come here with stage 4 disease, late-stage disease, more difficult to treat, more symptomatic, affecting quality of life. So we really opened the program to fix this problem in our community. Why do we have it again? Well, we're trying to prevent. We do this as a service to the community. We're doing this because we want, we care about the families that live around us. We want to diagnose cancer earlier. The program for screening for lung cancer is very accessible and is very reasonable in cost. The medical requirements is just like in the clinical trial, the one that I mentioned before. You need to be between 50 and 80. You do not need to have signs of symptoms of lung cancer because for that, you do a diagnostic test. You need to be either a current smoker or you quit within 15 years. If you quit more than 15 years ago, the screening study is not that helpful. And then you need to have more than 20 pack year history of tobacco. How do you count the pack years? How many packs you smoke in a day times the number of years. And then, of course, we also follow the NCC guidelines, which are very, very similar. How do you initiate to do this screening? You don't have to be a patient of CCARE. You don't need to be referred by a primary care physician to see. Call us and mention that you want to be screened for lung cancer. There's also, we have our website that people can actually go online, find the link for the lung cancer screening program. You can link in there and ask for a referral right there. We'll make it very easy for the patient. And once you come to the office, it's very, very simple. There's a registration paperwork that will take 10 minutes to get it done. You're going to have a quick 10 to 10 minute visit with a nurse practitioner to make sure that you're a candidate for the program. And then we can get the LDCT scan done, and it can be done in 5 minutes. And so you can all review the screening program within 1 hour. The technique itself can take only 5 minutes. Use the imaging disc and written report. If lung cancer diagnosed, can schedule follow-up with any oncologist they want in the community, and we can see the patient within 5 days. And if the scan is clear, we just schedule the follow-up in 5 years. Remember that at national clinical trial, they followed these 53,000 patients for 10 years. Total ionizing radiation was very, very limited. I do want to mention here again that if you compare C versus LDCT, is 90% less delivery of ionizing radiation on the low-dose CT scan. So it's very, very safe. The cost of doing the test is not very expensive. Medicare has approved it to be paid. I am sure that most private insurance, because Medicare pays for the service, most private insurance will pay for the service. Otherwise, it's not very expensive. The national cost is around $83 to $500. So it's very, very affordable for patients. I mentioned here on this slide the exposure to radioactivity, and it's very, very limited, as you can see here on the millisieverts. I'll give now the microphone to Dr. Lamon. Thank you so much.
Appreciate the comments from Dr. Flores and Dr. Bessudo. This last part of the talk is talking about how to prevent lung cancer. Well, of course, number one issue is to stop smoking. In fact, many of the studies showed that quitting smoking was essential as part of lung cancer screening. And achieve that through a variety of resources, often states and public health services. The number 1-800-NO-BUTS, B-U-T-T-S, is a service, I think, sponsored in the state of California. The issues also that we touch on, tobacco cessation, come about with the entry into low-dose CT program. It's called Shared Decision Making for Evaluation and Treatment. And that's part of the Medicare program, and it is required. That's why we have a nurse practitioner involved in this as well, to review not only the nature of the screening study, but the smoking history, and to help direct current smokers into smoking cessation efforts. I want to go on to another slides here. If you move through a few slides. To talk about something that's going to become very popular, those are e-cigarettes. We see many smokers who are really addicted to nicotine. As often said, the cigarettes are a drug delivery device, and the drug is nicotine. They're moving to e-cigarettes as a way to get away from combustible tobacco, with the bargain that there will be less chance of lung cancer. Most of the patients don't taper off of the nicotine with that or other tools, and are continuing to use vaping, non-combustible delivery of nicotine. Fortunately, it contains harmful substances, even though it doesn't have the tar of regular cigarettes. And there is a small fraction now of acute lung injury with vaping that's occurred in all ages, but it still puts nicotine into someone's bloodstream. Relative value of that is not the scope of our discussion, but it's still an addictive. E-cigarettes might help taper off if that's an effective tool. Nicotine is not reduced. E-cigarettes have fewer carcinogens than conventional cigarettes. However, the long-term safety of e-cigarettes aren't clear. We just, at the beginning of the talk, I went over the history of the association with tobacco, combustible tobacco, and lung cancers. We've only had a few years of e-cigarette exposure. We really don't know the long-term effects of e-cigarettes on general health or lung health. And certainly the e-cigarettes, for those who are trying to quit smoking, are being superimposed upon chronically injured lungs from past tobacco. They have chemicals, formaldehyde, heavy metals, mercury, lead in the vapors. Some of the particles, as you know, can lodge into the alveoli. There's also chemicals in the flavorings that can cause inflammation in the airway. The issues of what's in the vaping, they've speculated on vitamin E. Acute respiratory illnesses, as I mentioned, are a small percentage problem, but uncertain how they may affect the population. And I can't talk at all about what age groups and risk groups. I don't have that information. I think the issue at hand is people are trying to figure out ways to reduce risks of lung cancer. And as we've demonstrated or discussed, and what's been demonstrated is 95% of lung cancer is smoking. And so the number one means is to reduce that risk. radiation exposure is important. Radon exposure in people's homes is a topic of concern and evaluation. I don't know that there's any specific areas that are a problem for that, but it's something that is addressed, especially when home ownership. Now, the concerns with screening programs we didn't mention, and this is an important issue and why Medicare wants a shared decision making. That is that there are false positives. In fact, there's as high as 90% of CT findings may find a false positive. So we alluded that if you find an abnormality, we may have cancer, we want to diagnose this. But in fact, a positive finding, whether truly positive or false positive, opens the door then to diagnostic studies. And what Medicare in their decision-making process wants individuals who participate in this to know that there is risk. There is risk in finding an abnormality, risks of tests that may not be done otherwise, risks of anxiety, people that are quite fearful of worrying that they have a cancer. In fact, that's what may keep many people away from the low-dose studies. And finally, although it seems obvious, and that is the risk that if you have lung cancer, you'll get treatments. But in fact, we need to be aware that many findings will not be lung cancer, and they will lead to diagnostic studies and other interventions that individuals, even the physicians treating them, are not happy about, but in fact are obligatory when we find an abnormality. The other, I mentioned emotional effects. Most nodules won't be lung cancer, and there's also maybe very little association between a lung cancer risk and the patient's perception of risk. That is, they have a fear of treatment and a fear of death, and they're stewing about this as we then open the door to evaluating an abnormality. Overall, we have to decide, what are the criteria, and we know it's age. We mentioned that for criteria, and the smoking history. That makes it very clear who needs to be screened. Finally, to mention this, some of you may know about lead time bias and length time bias. These were biases that were looked at in the study, and the bias is in screening, the things that may make us feel that screening is effective when maybe it isn't. The fact that we're reducing mortality really diminishes the lead time and length time bias, and I'll explain that. The lead time bias would be that if you diagnose the cancer early, then you will assume that patients live longer by only attaching the earlier diagnosis to their length of life, and therefore you think you're helping them, but maybe you're not. The length time bias may be pertinent to some aspects of screening, and that is that screening programs that are at intervals such as 1 year are going to pick up cancers that are slow growing, and the cancers that grow rapidly are likely to be picked up with symptoms in between these screening intervals. So again, your bias is that you may be picking up only the good prognostic cancers and not those that are more virulent. But again, the study showing the 20% mortality reduction has greatly diminished these concerns about bias. Now, we've explored a lot of issues in this talk, and there's plenty of time, I think, for any questions that people may have. Any questions from the attendees?
Thank you so much for that information, Dr. Lamon. So if anyone has any questions, you can go ahead and type that into the chat box or go ahead and just unmute your line. Give them a minute.
Yes, how long does the scan take when people come in to get the scan done, Dr. Lamon?
The scan itself takes about 5 minutes. There's no contrast. Our technologists who deal with the CT screening can easily place patients with opening slots in between other cases. So we can tie all of this up by meeting with the patients, having the intake in the same physical site where the CT scanner is. And the process is very efficient. Any other questions?
All right, any other questions?
I have another question. If I am curious about the long-term effects, or if I've had COVID recently, what would you recommend and how can CCARE help me?
Well, I want to get some clarification. You mean if you're having respiratory problems from COVID?
Correct, yes. If I had respiratory problems from COVID and I'm just concerned about the long-term effects, what would you recommend and how can CCARE be helpful?
Well, probably just on the surface, that's not a job for oncologists, but your primary physician. But in terms of the fact that if you're a long-term smoker and meet these criteria and you feel you're short of breath, then in fact, it's certainly an area of concern of whether your shortness of breath that's extending beyond COVID is related to COVID or could be some other factor. And certainly that's a reasonable point in time to ask the question and either through your primary doctor or your own motivation to have a low-dose CT screening.
What if I'm not, Dr. Lamon, what if I'm not a smoker, but just I'm really concerned about, family history of lung cancer and would I qualify?
Well, I think in terms of qualifying by Medicare criteria, you wouldn't. But each physician deals with patients in those ways. The purpose of the shared decision-making would be to discuss those very points with patients and point out that from a payer standpoint, it probably would not be covered, and that whatever we may find may open the door to concerns and anxiety and future evaluations. But in fact, we would not keep anyone from having a study if they wished. This is an area that isn't touched upon too often in healthcare, and that's really discretionary spending, that someone should have the ability to choose what they wish to have but in our cases, and with shared decision-making, be well informed before they embark upon that or have any cost to themselves of what this is all about and what they might be able to get from it.
So that's good to know. I could still pay for the scan out of pocket if I so chose to, if I so wanted to.
That's correct. As long as we do the shared decision-making, the same as Medicare requires, and review the study, what it's about, what it may find, what the ramifications of abnormalities would be, that certainly it would be any individual's choice to wish to do that. And we see no harm in the low-dose screening in terms of radiation exposure and getting that information.
Thank you.
All right, I don't see any other questions coming through. Thank you so much for this presentation tonight. We appreciate all of you taking time out of your busy schedules to provide this information to us. If anyone has any further questions, you can go ahead and send an email to moask@moask.org and we'll forward it to the CCARE team for answers. This concludes our webinar, so have a great evening.
Nicole, it was a pleasure presenting for you.
Absolutely. Thank you so much.
Thank you, Dr. Lamon.